Good evening, all. Welcome to this ESU Online UROwebinar. My name is James Sindar, Professor of Urological Surgery in Aberdeen, Adjunct Secretary General in the EAU, responsible for the education portfolio. It's a real pleasure to be here with you all. We have a great faculty. This webinar is focused on a project called Imagine, which is Measuring Guidelines Adherence as an important pan-European collaborative project. As you all know, guidelines are only beneficial to patients if they are actually used or implemented properly. A huge work goes into preparing these guidelines. A lot of effort goes into synthesizing the evidence at a huge cost. We do know that huge patient outcome benefit is achieved when we implement what we already know works and for which there is evidence. So the Guidelines Office, we are extremely proud to have been part of a project with national societies, 31 national societies actually, across Europe, representing about 187 hospitals, in delivering this first pilot project, looking at one particular guideline recommendation from the prostate cancer guideline, for which there is no debate as to the certainty of the evidence. So in theory, everybody should be following that recommendation. And so we will hear from a number of presenters today from the Imagine group of the Guidelines Office. We have with us, of course, the first presenter, Dr. Stephen McLennan, who will look at what we can do to address evidence practice gaps. He will talk to us about implementation science methods and so forth. And then we'll have Professor Nuno Azevedo from Porto, who will talk to us about the platform that was used to collect the information that we presented today to you all. We will then have Jennifer Dunsmore from Aberdeen, who will talk to us about the methods and interventions that have been used in what we will call implementation science and how we can understand behavior of clinicians in this arena. Finally, Professor Phil Conford, who is now the chair of the Prostate Cancer Guideline, will talk to us about the opportunities and the projects that the European Association of Urology has embarked on to not only produce high-quality guidelines, but to actually collect real-world data to understand practice in the front lines so that we ensure that patient care and patient benefit is achieved. So without further ado, I will invite Dr. Stephen McLennan to give his first presentation.
Thank you very much for your introduction, James. I am Stephen McLennan. I'm an academic. I work in the academic urology unit in the University of Aberdeen. And although I am presenting this work to you, it's been possible via funding from the EAU Research Foundation, but also my collaborators across various aspects of this project, some of them here presenting to you this evening. So when we talk about, I have no conflicts of interest for this presentation. So when we talk about implementation, what do we actually mean? And there are lots of terms that have been used to describe essentially the same concept. But the one that we use and the one that seems to have gained most traction in recent years is implementation science. So what do we mean by that? So here are some basic definitions. So a scientific inquiry into questions concerning implementation, that is the act of carrying out an intention into effect. So when we speak about that in the concept of in the context of health research. That can be policies, programs, or individual practices, collectively called interventions. So these are typically the things that end up being recommendations in guidelines, such as the EAU guidelines. And it can consider any aspect of implementation, including the things that affect the processes and the results of implementation. And a part of that definition here is to introduce potential solutions into a health system on how to promote their large-scale use and sustainability. So we'll give you some examples this evening on implementation research. So how can we help to improve clinical practice? Sorry, give me 2 seconds. So there are many models of implementation. You may have heard of some of them. I just highlight 3 of them here: the knowledge to action cycle, the consolidated framework for implementation research, and the behavior change wheel. And the one that we will focus on this evening is the behavior change wheel. I won't talk a whole lot about it just now because it forms the basis of Jennifer's presentation. So I will leave her to give you more of an understanding of that. So basic point is that there are common things that all of these frameworks cover. So if you have an evidence practice gap, you really need to know the extent of that picture. So you may suspect something's happening, or you may have some small scale audits, but you really need to understand the extent of the problem if you're going to do something about it. And importantly, it gives you a baseline. If you want to measure change, you need something to measure it from. So auditing current practice, and that can be done in a number of ways, prospectively or retrospectively, and I will give you an example of that. So that's one of the common themes in implementation research, is understanding current practice. Beyond that, you also want to understand, well, why do people not follow the guidelines? Is it because they don't know about the guidelines? Is it because there are systemic reasons why they're not followed in a particular hospital? And again, Jennifer will give us some insight into how we go about knowing the reasons for discordance. And as part of that, we also want to understand the attributes of the individuals who are responsible for introducing improvements in the context in which they operate. So James introduced the example that we're mostly focusing on this evening. So there is a recommendation in the prostate cancer guidelines: do not offer neoadjuvant androgen deprivation therapy before surgery. And that's based on good evidence, high certainty evidence, of a number of trials within a Cochrane systematic review. And within the Imagine group, we prioritized this recommendation through a process of trying to figure out, well, which ones is there a little room to maneuver in terms of adhering to that guideline. There were some studies, I remember an Italian one, and there were a few others of country level audits of ADT use showing problems within countries, but there was no European picture. So we decided to try and solve that problem. And the way we decided to do that was a retrospective audit of ADT before localized prostate cancer surgery. That was only possible through using the European Association of Urology Guidelines Office network to help engage the national societies. And really, this project wouldn't have been possible without them. And they were contributing data through a bespoke platform. And again, Nuno will introduce that platform and give us a bit more of an idea of the practical processes of how we collected that data. But I'll just run quickly through some of the results of that project. So there were over 6,500 cases we collected data on in 187 hospitals across 31 countries. Mostly adherence was quite good. Most people stick to the guideline to not give ADT before surgery. But in that high risk group, these the high risk and the locally advanced group, these purple dots, adherence, the non-adherence was slightly higher, and the range was from 0 to 43%. Some of the reasons for non-adherence were that the patient had already started on radiotherapy and then changed their mind because they found the side effects of ADT intolerable. So that's an example of one of the reasons, and I will leave some other aspects of that for Jennifer to speak through when she speaks about how we collect reasons in a more a way that gives us a better understanding of that. Perhaps a limitation of our study is that the institutions that participated were perhaps already guideline aware, so we may have underestimated non-adherence, so we might be showing a more positive picture than exists in reality here. But the main take-home message is that there are still lots of men in absolute numbers that needlessly receive ADT, so they experience the side effects of a treatment that they do not need. So what are the next steps typically in an implementation project? So once you understand the current practice, you want to understand the barriers and facilitators to practice in terms of practicing in accordance with the guidelines. So you need to understand the context in which people are operating, and you need to understand the perspective of all the people who are involved in enacting a complex intervention, because it's really the responsibility of one person. Even something like giving ADT, it's okay, it might be the urologist that prescribes ADT, but the patient will have some influence on that, and the rest of the urology team, they may discuss that case at, for example, an MDT meeting. And a major point I'd like to make there is that you need researchers trained in qualitative methods to do that work. It's not straightforward to do that work. Beyond that, then you want to design interventions based on those barriers and facilitators, and ideally you would use behavioural theory and prior studies to inform those interventions. Then we want to test the intervention, and similar to intervention effectiveness in clinical research, an RCT is an ideal study design to be able to control for known and unknown confounders, but there are other study designs, for example, controlled before and after studies, but there are internal validity threats to some other study designs that are often used in this context, so they can become quite complex, and you really need to have a dedicated statistician working on such examples. So I'm going to talk through quickly one urology example, and I'm deviating slightly from our ADT example just because this example is a little bit further forward in the research process. So this example is about giving or the management of non-muscle invasive bladder cancers with TURBT, and it's based on 4 quality indicators that there is evidence to show that they are associated with cancer outcome. So having detrusor muscle present in the specimen, single installation of intravesical chemotherapy, documentation of the resection, and documentation of the tumor size, number, location, etc. in the operative record. So Resect's design was that they had a baseline retrospective audit. The study is ongoing, so we don't know the results yet, but there was an embedded RCT. So after people provided their baseline audit data, they were then randomized to either receive the intervention, which was audit and feedback, to just participating in the audit and receiving no feedback. And the outcomes we were interested in are improvement in the quality indicators and early cancer recurrence. So that's an ideal situation where you have the behavioral outcome, but also a hard clinical outcome. And I don't want to go into any of the differences between the UK and non-UK. It's just this was one of the slides I had that gives some of the baseline data. But the point I want to make is there is room for improvement in all these quality indicators, particularly the single installation quality indicator. So the take-home points from this part of this evening is that evidence practice gaps exist. Understanding baseline adherence is key. We want to know if we do something to affect change, that it was due to something that we have done. So study design is key as well. Implementation science provides knowledge. It can give us some information on how we can change clinician behavior to improve patient outcomes. Another main point I want to make is that these types of projects require multiple expertise and research methods. So for understanding practice, we need epidemiology and statistical information for these widespread clinical audits. For understanding barriers and facilitators, we need qualitative expertise. For intervention design, and we need behavioral science input. And then for implementation trials, we need the same kind of expertise we would need for any randomized control trial. And the designs can be quite complex. And of course, a major point I want to make is that multidisciplinary collaboration is wise. So thank you very much for your time. I am now going to pass over to Jennifer for in fact, I'm passing over to Nuno next. He's going to give us an overview of the Imagine platform. Thank you for your time.
Stephen, thank you ever so much for that. Can we just remind all the participants on the webinar, firstly, thank you for joining the webinar. We do have a question and answer button at the bottom of your screen. We will encourage you all, if you have any questions, to use the Q&A chat function to pop your questions in, and Stephen can answer any questions you may have about his presentation, and generally any question you may have about the Imagine project. If you pop into the Q&A, we'll try and respond as we go along. Thank you. So Nuno, can we now have Professor Nuno Azevedo from Porto, who was instrumental in building this platform that we used, actually. Nuno, do you want to come on and show us your...
Yeah.
Thank you.
Well, thanks for the introduction, and thanks for setting up this meeting. Can you see my screen?
Yeah.
Yes, we can.
So the overall aim of the Imagine project was to make sure that our guidelines, which are high quality, are actually used in the real world. As you know, this is instrumental to make sure that our patients receive the appropriate care. And it's even more important in the case of cancer, as we all know, because we have strong recommendations of what should and what should not be offered to our patients. And that's why for the first step for the Imagine project, we started with an audit of not offering ADT, so androgen deprivation therapy, before surgery. The issue then is, how do we measure this in an easy way to make sure that we have a strong data from across representation of what happens in Europe? So since we could not find a solution, we decided to build our own bespoke platform to make sure that we collected the data in a safe place and according to what was needed for this study. So after a meeting with the several national societies, we identified in each country participating centers, and within each center, there was to be a coordinator that would be responsible for collecting such data. So when you receive an email to participate in the Imagine clinical audit, afterwards, you define your own password, and when you log into the system, you have some idea of how easy it is to use. First, you were shown the name of your center. Here, for demonstration purposes, I just put in Public High Volume Academic Center, because for this study, we wanted to have a broad representation of what happens in Europe, and we decided to group hospitals in high volume and low volume hospitals, and this varied if they did more or less than 50 radical prostatectomies per year, if it was a public or a private institution, and whether or not it was an academic or a community center. So when you log into your specific center, you will see your own characteristics. Moreover, you also have this simple dashboard that shows you how far you've come. So this is the beginning of the study. As you can see, I have 0 complete cases, 0 incomplete cases, and 40 empty cases, because taking into consideration that this was a high volume center, we asked them to collect 40 cases, and for low volume centers, we asked them to collect 20 cases across multiple years. So because this recommendation, the do not offer neoadjuvant deprivation therapy before surgery, is a strong recommendation and has been in the guidelines for several years, we decided to start the audit in January of 2017, and that's why this is the date for the first case. We decided to use random dates within this bespoke data collection system to avoid having bias in the selection of the cases. So to start, you would just click on Edit Case, and the first screen, you will be shown the inclusion and the exclusion criteria for the ADT audit. And in this case, it would be for the inclusion criteria would be patients with adenocarcinoma of the prostate who had underwent a radical prostatectomy with curative intent, both for locally and locally advanced prostate cancer. And the exclusion criteria were metastatic patients or patients which were participating in a clinical trial. So after you confirm that you were aware of the inclusion and exclusion criteria and that the patient could be included, you would go on a step-by-step manner, because the platform understands your answers and it prompts you different questions depending on your previous answers. So, for instance, was the radical prostatectomy performed on the suggested date? And if yes, you just continue. But if for some reason there was no procedure on that day, you could always change for another date when the first radical prostatectomy that could be included in the study was performed. And we opted to use random dates to make sure that the cases were representative of what happened in that center, and that there was no selection bias. Another way of avoiding selection bias was to make sure that we wanted to know if it was the first radical prostatectomy of the day or not. Also then asked for several clinical information, such as the PSA level, Gleason score, and a tumor node and metastasis classification. And if you look closely, every time I give an answer, the platform checks if everything is going okay and according to the expected answer, and if it needs to change the next question. Moreover, we wanted to know if this case was presented in a multidisciplinary board meeting, which for this study included one urologist, one oncologist, and one radiotherapist. And then we get to the main issue of what we wanted to know, which was androgen deprivation therapy given prior to the radical prostatectomy in this case? And if there wasn't, fine. And as you can see, the complete button now is made available, and I could just carry on. Or if there was, if ADT was given prior to the radical prostatectomy, there were some examples of possible ways of such ADTs, such as surgical castration, anti-androgen or others. And another very important part of the audit was there a reason explicitly recorded in the patient chart that would explain why ADT was given? For instance, like Stephen said, one of the things that we found is that some patients started on ADT because they were planning on doing radiotherapy, but they had to change their choice for radical prostatectomy because they did not tolerate the side effects. So some of the reasons that were included was the reduction of prostate volume before surgery, the reduction of tumor volume before surgery, the less risk of positive surgical margins, long waiting lists. This also happened a little bit, the audit date also included a little bit of COVID overlap and also at request of the patients. So all of these were possible, and if not, you could also record other entries to explain why this was the case. After you hit complete, you can confirm that that was the case, and now you have one complete case, no incompletes, but 39 to go. And as you can see, the random date generator prompt you for another case. And you would just move along and do this for hopefully all the expected cases in your center, which in this case would be the 40. We found that this was we tried to design the platform in a very easy to use manner. And from our experience, if you had the data for each case readily available, each audit took between 1 and 5 minutes. And as you can see, you would just move along until you reach the number of expected cases. Each audit had its own specific ID, and this is one of the ways we designed to make it easier to follow in pending queries or some doubts that some users had in this study. Another very important part is that you can only see the data that you are entering. So you could not see any other participating centers, and this helped with the anonymity of the data so that you could collect without being afraid of being pointed out either as a good or as a bad example. So this is what the participating centers saw. And is very similar to what the study coordinator saw, with the difference that they have a global view of all the participating countries, and they can follow up in real time what has been happening. Who is entering more cases, which are centers that are still haven't started, which are ongoing, etc. Moreover, for the participating center, they can always go back. They cannot change the data after it is entered unless they get in contact with us and ask for it to be changed. And for that, we would need to break the seal on this record and make it available for edit again. And this was used to make sure that the audit was very straightforward and that there was a sequence in the randomization dates, which would, again, avoid any bias in the selection of cases. And from me, that's it.
Thank you very much, Nuno. Thank you ever so much. I think one of the participants was having a challenge in hearing, but I hope they've solved the technical issue for them. So please, if you have any questions on Stephen McLennan's presentation or Nuno's presentation, please just put them in the chat function at the bottom. It says Q&A. If you use that button and that chat, that will be really helpful, and they will answer your questions in the chat as we go along. Now I'm going to invite Jennifer Dunsmore to come in now and give us a little bit more of an overview on the methods and interventions that we use in implementation science to try and understand better the behaviors or reasons why adherence is not possible sometimes. Jennifer?
Thank you. I take it you can hear me okay?
Yes, I can hear you.
Grand. Yes, as James says, I'm Jennifer Dunsmore. I'm actually a PhD student based at University of Aberdeen within the academic urology unit, supervised by Stephen McClelland. Today, I will be giving a bit more of a kind of behavioural side of things, as well as the research methods and intervention development process I have used in trying to understand how best to overcome this sort of, discordance that we're seeing regarding ADT use. So just before I get started, I have no conflicts of interest to report. The first part of implementation science is to actually understand if there is an evidence practice gap. So it's been said many times in this webinar that we need to understand where the evidence is and what the evidence is, which has been shown to be well established and high certainty indicated as strong. One of the recommendations around ADT practice in the guidelines, but there's also other parts of literature where I've managed to pick out and see that other countries are struggling or, having this impression of evidence not translating into practice. So it's a very clear gap that we are able to see to move forward in the implementation science process. So this leads me to my research question. Of course, I focused on this particular guideline, which led me to the research question of wanting to understand the barriers and facilitators influencing clinicians' ADT prescribing behaviour in high-risk prostate cancer settings. From a behavioural science point of view, we can use this intervention design process, which is a three-stage process to design an intervention that is going to enact on the behavioural influences underpinning these treatment decisions that are being made. The first stage is also known as a behavioural diagnosis, defining the problem, understanding the target behaviour, and identifying the influences underlying that behaviour that may need to be changed. One way of doing this behavioural diagnosis is by using tools offered by health psychology, which is one field in the discipline of behavioural science. As you can see here with the wheel, the inner part, the green part, are sources of behaviour. These things need to happen in order for a behaviour to be enacted. The influences on these behaviours are highlighted in the yellow, which is known as the theoretical domains framework. This is part of my project that I have used to identify these behavioural influences on treatment decisions. It's part of a bigger picture. So once we understand the sources of these behaviour, as well as the behavioural influences, we can then link these to intervention functions, which is in the red, and possible policy areas in the grey, such as guidelines, as we've seen today. Like any medical diagnosis, I needed to collect some data. It should be said that this particular project for my PhD is based in other countries, in 2 different countries of the UK and Italy. However, I've not had chance to do any analysis on my Italian data, so I'll just be presenting the UK data so far. I spoke to 12 different urologists that were based in 9 academic high-volume sites. They had a range of experience, and of course this was done within the COVID-19. Sometimes we came across restrictions that were maybe not relevant to usual practice, but these were also discussed. So it's a bit of a busy slide. I'll do my best to explain it as easily as possible. So these are the 7 different behavioural influence I found to underpin the decision of using ADT in this particular context. As you can see, tagged next to knowledge, there were mentions of the evidence saying that it doesn't improve outcomes. That's why we don't give it, said participant 1. And participant 11 underneath that saying there's no evidence to suggest downstaging actually happens, hence we don't tend to use it ourselves. So knowledge was being influenced by the evidence and the type of evidence that's out there. Another couple of examples, environmental context and resources, further down the list. We can see that having a multidisciplinary meeting once a week allowed these particular treatment decisions to be discussed. And finally, social influences were also a main influence of treatment decision making. As you can see from participants' 12 quote, we were talking about guidelines in the use of clinical practice, and they were saying that they thought most urologists use guidelines as a template to protocolize or be used against their clinical practice. So they were gaining some sort of influence of knowing that other UK urologists were referring to these guidelines. I distilled it down again and tried to make it less complicated, but it sometimes can get more complicated, of the determinants related to this usual practice based on the facilitators and the barriers. So as you can see on the left-hand side, appropriate decisions, treatment decisions were facilitated by guidance. So the acceptance of the fact that they were evidence-based, having knowledge of these, and as well as UK urologists understanding other people were following them. A second example that I've boldened for clarity is communication with colleagues. I had many discussions about the usefulness of MDT in allowing discussion and standardising practice within a team or across a hospital. However, sometimes appropriate treatment decisions were prevented. In the specific case here, patients kept being brought up as a barrier to appropriate decision making. As the points made by Stephen and Nuno so far, this idea of patients having the ultimate decision and the kind of control on their treatment, this kind of patient-centred approach that healthcare takes, ultimately can prevent appropriate treatment. I also looked at this from the COVID-19 practice perspective. As you can imagine, not a lot facilitated appropriate treatment, although paradoxically, service provisions being changed or reduced, for example, less patients presenting to GP, and then less patients on MDT lists and subsequent surgery lists, actually facilitated appropriate treatment regarding hormone use. Whereas there were many barriers in the case of COVID-19 practice. Surgery capacity was significantly reduced across the board, and these COVID-19 restrictions and regulations, whether that be red and green hospitals, giving extra resources to COVID-19 patients, all kind of led to delays in surgery being offered. Some urologists, actually the majority of my sample in this interview study, offered hormones, even if patients were going on to get surgery, they offered hormones as a stopgap, almost as a way of trying to ensure they were getting some sort of treatment, because the delays and the restrictions of COVID-19 really were uncertain at that point. I've highlighted their emotion as I didn't find this in my usual practice determinants, but during the COVID-19 kind of influence practice, lots of people were reporting that they were worried about not being able to provide a treatment or providing treatment in time, and actually adding hormones in as a stopgap reduced not only clinician emotion towards this, but patient emotion in ensuring that they felt like they were getting some treatment in a reasonable amount of time. Final couple of slides. I just wanted to kind of give you a bit of an insight into how I'm going to use this information. So I've done a worked example. I've built my behavioural diagnosis. I can understand what is underpinning these particular behaviours and treatment decisions. So, for example, knowledge that evidence does not support the use of hormones before surgery influences appropriate treatment decisions was one of my codes. What I can do then is set that back into the literature and behavioural theory to understand which intervention functions and policy areas would be helpful in ensuring this continues to be the message. So things like education or training interventions can be facilitated by policy areas such as guidelines. The final step in this process is identifying the content of these interventions. Things like active ingredients, also known as the behaviour change techniques, help us ensure that the content is influencing that underlying behavioural influence. So things like information about the health consequences and the pros and cons of offering hormones before surgery, for example, being written into the guidelines can facilitate that underlying knowledge, which can influence appropriate treatment decision. So in conclusion, and our kind of take-home points, this three-step intervention process allows consideration of these very important aspects of developing an effective behavioural intervention. The theoretical domains framework, highlighted in yellow, identified 7 areas of behavioural influence on appropriate treatment decisions regarding ADT before surgery. The behaviour change wheel facilitates selection of appropriate intervention functions and policy categories. And finally, the content or the behaviour change techniques helps ensure that the intervention contact has an impact on these important and identified behavioural influences. Thank you for your attention.
Jennifer, thank you very much for that very nice presentation, and very grateful to you. Can I again encourage attendees, if you have any questions, please use the Q&A chat function to put your questions in. We'll try and answer them as we go along. Now, can I invite Professor Phil Conford, who is now the chair of the Prostate Cancer Guideline, to talk to us about the initiatives that the EAU is taking to try and understand what's happening in the real world. Phil?
Thank you very much for an opportunity to talk about something which we can all get involved with. You've heard a lot about understanding how people react and how the data is collected and what you can do if you understand the data. But this is an opportunity for you to learn something about what you could do to get involved with this process. These are my disclosures, and some of them are sort of relevant because some of these are consortia that are run with pharma. So imagine you've heard quite a lot about. It is an attempt to assess guideline implementation, and to date has been very prostate cancer focused, which is perhaps why I have been invited to be involved here. But it doesn't have to be just prostate cancer focused in the future. And most importantly, it showed that as a European community, we are capable of working together to collect data, not just from big academic centres, but from across Europe and from different sorts of centres, different people working. And I think that is the really important thing in terms of the data hub. Pioneer, you'll probably be aware of. It was the development of a European network of excellence for big data in prostate cancer, and very much an aim to improve prostate cancer related outcomes and efficiency of the system. They have carefully collated a big data platform, and there are currently 95 different prostate cancer data sources identified and 23 data sets that can be used for analysis. It's allowed them to work on developing core data sets and beginning to think about online search tools for prostate cancer diagnosis and prognostic markers. something that is going to be difficult to do by any one centre. This is how it works. And I make no apologies for what is a slightly busy slide, but it, in one picture, helps you understand how this works and what will happen. So on the far side of the picture, it says knowledge gaps, and it's the knowledge gaps that need identifying first. When you understand where the gaps are, then you can begin to phrase questions that might be possible. If there is a good randomized controlled trial showing the answer, then probably this isn't the right way to go. But for lots of the things we rely upon, we find that there isn't a good randomized controlled study, and as a consequence, we're looking for other ways of filling up those gaps. These are some of the different sorts of questions that can be asked. You need to collect data from all those different sources, and you can see in Pioneer, because this is a joint project between the pharma industry and the EAU and academic institutes, you get a range of different sorts of data. Then you need to anonymize the data, and you need to homogenize it such that the data runs in a simple data process. So what you're looking for is to ensure that the vocabulary, the way that we hold the data, is standardized between the different data sets. And then that allows you to leverage the knowledge that is harnessed by being able to compare different data. And that's what this middle block is all about. And then that will allow us to answer questions as shown at the far end. So Optima aims to extend this. Optima is a more recent launched, again, a combination of the EAU, academic centres and the pharma industry. And this was launched in October 21. And again, it is designed to expand our knowledge. In many ways, it builds on the things that we learned in Pioneer. But it's not just for men with prostate cancer, but it's going to expand so it deals with patients with lung cancer and breast cancer at the same time. And because we understand some of the core data sets that were created out of Pioneer, we then begin to be able to use artificial intelligence-driven technology and tools to expand that so that we can then begin to make improved decision-making, empowering patients, and perhaps in the not too distant future, computer interpretable guidelines that would allow patients and clinicians to have an open discussion about the risks and benefits of different treatments. So that brings me to the UROevidence Hub. Those of you in Milan will remember that that was the first place that this was really talked about, and increasingly we are moving towards a stage where we will be able to begin to put data into a data hub. So why? So what we're hoping is that the EAU will be able to generate a data hub which will give us the ability to answer some of the questions that we haven't been able to answer up until now. We believe that in big data, there is the potential for real improvement in healthcare and being able to drive decision-making, but only if we have the diversity of data that this sort of a system would allow, and beginning to develop the sort of software and infrastructure that would be required. It will again be dependent upon you, the people watching, and those people in wider, the national societies and associations who will be invited to collaborate. We will have our own control environment to explore the sort of advances around the incorporation of real-world data that will allow us with certainty to be able to influence guidelines and policies. And everything you've heard so far has been about cancer. But urology is much more than just cancer. And in this ecosystem, it will be possible in the future to be able to collect data for other different important urological diseases. And then we'll be able to expand the things we've learned in prostate cancer into help patients elsewhere in urology. As we've said, there are currently large evidence gaps in clinical practice, and some of the things, there is no way that a high-quality clinical randomized trial will ever occur. And we're also aware that the sort of people that get included in a randomized trial often are not representative of the sort of people that we meet in clinic. And so if we collect real-world data, we'll be able to do that. We'll also encourage patients for them to put outcomes in so that we get feedback from patients about exactly what the long-term consequences of the treatments we give. And that will not only be useful to us as clinicians, but will be useful for regulators trying to understand how new treatments might be effective, and for pharma companies who want to be able to be sure that the treatments that they are developing will get approval and access to markets and be able to look at post-market assessment. So this is the sort of thing that we're thinking about. There'll be a registry, there'll be PROMs and PREMs, and largely this will be inputted by the patients themselves. We've got a common way of recording the data, and we can then use those tools in order to analyze it. So what we're asking is that we will be able to get clinicians to enter patients' data into a registry, that you'll set up this registry. The patient will have a single record, so it doesn't matter whether they turned up with their prostate cancer, their incontinence, their bladder cancer, all of those will be under a single record. And then patients will be able to access the forms and use the links and help fill us out. So you'll put in the initial clinical data, that will set up the registry. The registry will send out for PREMs and PROMs. The patients will be able to fill in the form, and that will feed it all back into the registry. So I encourage you to look out for an opportunity to get involved in the UROevidence Hub. It is coming. You can't get involved quite yet, although clearly if you're interested, we'd be interested in collecting expressions of interest. There are 1 or 2 steps just to get going, but the platform is very much nearly built, and we should have more information about this in the second half of the year. Thank you very much for your attention.
Phil, thank you very much for that nice overview. And I know it's a short 10-minute slot to cover 3 very large projects, but I think that what was important is, as you stated, the reasons why the EAU is involved in Pioneer, why the EAU has been involved in Pioneer for close to 5 years now, the importance of that for your own guideline updates in the future, because real-world experiences may well be very different to what we see in trials, as you rightly say. And then expanding that to Optima and of course the excitement for the EAU is the implementing of the Euro Evidence Hub. This is really exciting, where we can over time make sure we capture the experiences of all patients with urological conditions, not only through their hospitals or their clinicians or their healthcare providers, but directly from patients. Now, are there any questions? And if there are, we've been answering some of them, of course. So thank you for those who have been putting questions into the Q&A chat box. And certainly some of these were around the possibility to collaborate with the EAU on future projects, Phil. You, Phil, will be very much also heavily involved in the Euro Evidence Hub. So a lot of the future cooperations will be coming your way, no doubt, but I've put in Natasha's email as a contact point for Imagine and future projects in Imagine, that people could at least register their interest, given that this project is now, this pilot is now complete. We're not recruiting anymore, but there'll be a follow-on project which is being planned, and there may be opportunities for attendees on this webinar to participate. I see there's another, there's a question around the security of patients' personal data. How is that ensured? I'm very happy to talk about that. We take, of course, security of patient information very seriously. If you imagine our experiences in Pioneer, where we have a huge number of data sets and access to patient records that we're using as part of the project. But this patient's data is anonymized, of course, and so we don't use patient identifiable data. And there are two ways of sharing on Pioneer. You can either share your data anonymized centrally, or you keep your data behind your own hospital's firewall, and we send algorithms to your data, and only aggregated results are shared with us. So patients' identifiable information is very much protected. And the project is GDPR compliant. We have an ethics and work package, ethics and legal work package. We have very robust processes and independent ethics advisory group. So we take all of this seriously. For Imagine, however, we will invite Nuno to talk about, or Stephen or Nuno, which one of you want to talk about how we've dealt with securing and ensuring that patients' data is protected?
Yeah, I can answer that. So there is no identifiable patient data. Everything is anonymized. So that way we are outside of the GDPR spectrum, and patient privacy is always safeguarded.
Thank you very much, Nuno. And I see Richard Sylvester has asked in the chat, by the way, thank you for joining, Richard. Professor Sylvester, for many years, was the chair of the methods committee of the EAU Guidelines Office, as well as a highly valued member of the non-muscle invasive bladder cancer panel. Richard says, will the forms that patients fill in be validated in the national languages? I think, Richard, you raise a very important point. This is something that Euro Evidence Hub, for which Phil will be the chair of the steering committee, will take very seriously, because we certainly need to firstly professionally translate all of the information for the different countries and languages that we'll be collaborating with. So certainly there'll be translations that will be done to make sure that, you know, we're not asking everyone to fill out questionnaires in English. Phil, do you want to? Yeah, Phil is also part of the patient office, of course. So Phil has in this.
Yeah, I mean, it's really important that people be able to fill it out in their own language. Otherwise, you get a very selected group of patients. So that's quite a big ask when you look across Europe. There are a lot of different languages, and there's no doubt that to begin with, like lots of other research tools, the prems and proms that we use are established things. They're not something that will be created for this. These are things that have already been validated. And because that's true, many of them are already available in other languages, having already been translated. So we will certainly start with those. The question is, if you there are no Spanish faculty, I can't get told off, but if you wanted a Catalonian version rather than a Spanish version, then I suspect that will be slower coming, if I'm completely honest. But to expect people in Spain to answer in an English version clearly is no good.
Yes. Thank you, Phil. Listen, we're coming to the end of this session, of this webinar. It is now 19:30 set. And firstly, let's thank all of the participants that have joined the webinar. It's been a real pleasure to be with you for this hour session. I would like to take this opportunity to thank, of course, Phil, Stephen, Jennifer, and Nuno, who have been absolutely formidable, not only during this 1 hour session, but they've been instrumental in delivering the Imagine's first pilot project. We look forward to cooperating with you all that are interested in collaborating in future projects. I would also like to take this opportunity to thank Professor Maria Riebel, who could not join today. Maria Riebel is the chair of the Guidelines Office now. And of course, Professor Alberto Briganti, who alongside Stephen McLennan is the coordinator of Imagine. So our thanks to all of them. So all the very best to you all. Thank you for joining us this evening, and look forward to sharing our experiences of Imagine, UROevidence Hub, and others, be it Pioneer, Optima, with you all in due course. So do join us again. All the very best to you. Thank you.
Thanks.
Okay, bye everyone. Thanks again.